Welcome to a Mosaic Clinically Integrated Network training and education session. This is Dr. Cortland Katayan, President and CEO of Mosaic Clinically Integrated Network. And the topic we're going to cover here in this session is really about the fundamentals of clinical integration, and is really designed to be a nice introduction to the Mosaic Clinically Integrated Network, why we have it, what it's for, and foundations and really value-based care. So what we're going to cover today is to first define value-based care. The second thing will be to actually then define the structure of the Mosaic Clinically Integrated Network. And then finally talk about services the CIN offers, as well as value-based care contract performances. These things are all interrelated with one another. So first of all, what really is value-based care? And value-based care is really rooted in this concept of the quintuple aim. The quintuple aim is something that started during the healthcare reform era as the triple aim, looking at patient experience, quality or population outcomes over cost. And you can see this original value equation is the outcomes of quality experience over cost. And that's how we really define value. Over time, it's evolved in this concept of the quintuple aim, and the quintuple aim adds provider well-being as well as the concept of health equity. And so value-based care, and the way that we really think about it within the clinically integrated network context, is how do we advance this quintuple aim? And if we do this, we're really being compliant with what we need to do as a CIN, and I think are going to be successful as an enterprise participating in value-based contracts. So if we use that as our context for defining what is value-based care, then we also need to think about why a clinically integrated network, right? So value-based care is really the environment, and then the clinically integrated network is the vehicle. And so the idea with a clinically integrated network is we take groups of providers who, by the way, don't all have to be employed in the same model. They can be physicians that are in private practice or employed by a health system, various different employment arrangements. We can come together as part of a clinically integrated network, as part of a CIN. And then the CIN brings certain capabilities, which here we have outlined as the 4 Cs. The first is around contracting and compliance. So there's specific real expertise needed for doing value-based care contracting, specifically around actuarial and certain types of accountability. There are capabilities that we bring to the physicians in the network, compliance, pluralistic culture, investment in population health management services, as well as reporting and analytics. We're going to cover some of these additionally. Compensation, there has to be actually a financial, or there is a financial impact of coming together. And so we want to make sure that we're enhancing the financial performance and then distributing those those resources out to the physicians within the CIN. And then finally, this idea of capital to help support and insulate physicians from the loss of risk. And risk is this idea that physicians are essentially taking on this insurance function and becoming accountable for the care of the patients that we see. Ultimately, we want to be able to deliver the best quality and outcomes, so that's achieving that quintuple aim really objective. And if we do that, then we'll be very successful in a value-based care environment. The Mosaic Clinically Integrated Network was incorporated July 1st of 2024. And our first year together in contracts started January 1st of 2025. In the first year, we were able to assemble over 600,000 lives. So that means these are patients who are served and are affiliated with our primary care physicians. And you can see this stretches all across really Southeast and Central Michigan, and it includes entities, both part of the Henry Ford Medical Group, our partners with Michigan State, what has been the legacy Jackson Health Network, and then elements of independent practices and Henry Ford Physician Partners, the largest footprint of which is in actually Macomb County. So we're really spread geographically all around Southeast and Central Michigan, and it's 4,500 providers and over 600 primary care providers. So really a very significant model in the first year of 2025. The framework for the Mosaic CIN is really built on what is designed to be an extremely compliant vehicle. So the idea of a clinically integrated network is that we can bring employed and independent physicians together and a model that's pluralistic for contracting purposes. So if all physicians are under the same employment model, you don't really need a CIN because physicians that are all employed, let's say by a hospital, can all contract together through that hospital's contracting function. But if we want to have physicians that aren't all in the same employment model and have them contracting together and be compliant from an antitrust perspective, we need a protective mechanism to do that, and that's really what a clinically integrated network is. It's a framework that's defined by the FTC and the DOJ that helps us come together in a way that is compliant and is not anti-competitive. And the government says, we're going to let you do that if you're basically going after those quintuple aim objectives and demonstrate that we're improving performance, quality, cost, utilization, all of those things over time. So that in this case, we're aligning our infrastructure across this really diverse, pluralistic, both geography and different practice environment so that we can succeed in value. The majority of our contracts are actually value-based at this point already. So this is not a future orientation. This is a current orientation. 80% of the contracts that we participate in as a Henry Ford enterprise are value-based contracts. And it's also finally a strategic vehicle for payer partnership as well as growth. What the wheel diagram is showing is really what are those tenets, so to speak, of clinical integration. And we're not going to dive into these in extraordinary detail, but there has to be really like a physician leadership and governance model, dedicated infrastructure to success in value. We have to hold everybody accountable to participation criteria and performance objectives, and then shared platforms where we can share data, information, which helps us reduce duplication of services. And then finally, the kind of benefit is how we share our incentives, and then that ability to contract together, which is really where the biggest opportunity is to drive value and performance on the physician side. I like to refer to Mosaic really as a drivetrain, and this is how we think about it, and it's really within 6 kind of core areas. So the first is this idea of credentialing. We typically or historically like to think of credentialing in terms of like the hospital environment, and I separate that to think about what is payer enrollment versus what is facility privileging, right? So privileging is really determining if a provider has the right experience to be able to provide a service in a facility. Payer enrollment is about getting synchronized with payer files and being able to be paid for services that are provided according to standards set by the payer. So what the CIN does is actually centralizes all payer enrollment with all payers, which significantly can accelerate that process. Contracting we've talked about, and that's fairly self-evident, having one place where we go and contract with all payers together. Analytics is this idea of being able to identify actions that drive our focus and decision-making process around performance. The clinical integration program is having one program where we align our pay for performance and quality objectives across all contracts, which then flows directly into our incentive distribution because clinical integration drives incentives, and then we have to distribute those incentives out to the members of our network. And then finally, having one administrative team that supports these various functions across this pluralistic model. And the idea is that here we're trying to evolve what we've done historically so that we can really focus. And when we're able to focus our energy and reduce some of the complexity, we're able to really drive performance. And that's what this is about. The CIN is about driving performance in value to deliver against quintuple aim objectives. So we're going to kind of talk about each one of these areas briefly. Credentialing is what we kind of historically, if you just allow the payers to take control of enrollment, it can take 6 to 8 months. And so this can lead to tremendous delays, both with access and then onboarding of physicians. And what we've done is we've delegated that process. So we actually take the CIN and become the intermediary between the provider and the payers. And so that means as soon as a provider is credentialed with our credentialing committee and through our board where those things gets approved, they're automatically onboarded with the payer. So we can reduce the time by a factor of 2 or 3 to really get folks onboarded sooner. And so what this has resulted in is a claim denial rate that is basically 0.1%. So it's a very low denial rate. And and that is obviously important for us in terms of onboarding, access, and then also reimbursement. Contracting, historically, actually, within the Henry Ford system, there were 6 entities that were providing contracting services to members of the medical group, believe it or not. And so this is actually bringing all physicians under one aligned contracting model, which it's easy to imagine why that's better from a payer perspective, right? Much easier to engage with payers and drive aligned performance when we have one contracting entity, right? This thing all sets up in terms of how we interact with payers and then kind of align our operations to be successful. And so now we do this as one collective unit, as opposed to kind of fragmented or using independent entities to do contracting for us. Analytics, again, is an area where we want to be able to identify opportunities for us to be able to perform. And really, like, this is maybe the case where we kind of failed to see their blind spots, what we could be doing versus what we should be doing. And now where we're at is to be able to couple how we think about contracting, credentialing, our clinical programs against quality with our opportunities and where we should be focusing the most to improve. And this enhanced focus is what's going to drive greatest performance and really understand where our levers are to perform. And so this is an evolving structure, and to have really sophisticated analytics engines really takes scale. So we really needed to get to this 500,000 life plus level to afford these types of investments. So we make very significant investments to understand where are our opportunities to drive performance in contracts that are value-based, and again, against those quintuple aim objectives. Then we come to this clinical integration concept, and many folks are familiar with the idea of pay for performance or PIP programs. And so these are kind of like the quality metrics that folks may be familiar with in various payer contracts. And what is usually the case is every payer has a different program. And so when providers participate in a dozen contracts, each payer with different targets, it can make it very difficult to perform against those metrics and targets. So just like with credentialing, where we basically delegated that process away from the payers into the CIN, for the pay for performance or the quality program, we've delegated that process from the payers to the CIN as well. So that means we're really going after one single quality performance, comprehensive kind of program, and that allows us to really focus and then drive performance. So we have the same metrics and the same interventions that we can then apply against those metrics as a network. And that's extremely important and allows us to really, really drive performance to a high level against obviously local, but also national standards. This is the first scorecard we actually came out with in 2025, once we were in contracts together. And the idea here is just to kind of get a sense of what is categorized in each bucket. So there are 6 bundles in what we talk about as like a network or a community scorecard. And bundle 1 has preventive and chronic disease measures, right? So very typical kind of HEDIS metrics that are driving things in those bundles. And then chronic 2 is, or chronic disease, or bundle 2 is more about chronic disease management, things like hypertension and diabetes and kidney health. And then we get into areas that are more about care continuum or cost and utilization, which is what bundles 3 and 4 represent. So very familiar things here like readmissions or cost. And then this is obviously trying to reflect that whole quintuple aim framework. So we have patient experience measures and then also some citizenship. And it's very normal, by the way, that in the beginning of the year, the score feels relatively low. So to score in the 40s in the first pass is actually pretty good. And the goal at the end of the year is usually be between about 70 and 80%. In this first year, it looks like we are certainly tracking in that direction. And so this is actually pretty good performance. So more about here is just to kind of understand what's on that scorecard and what drives those incentive dollars for us as a network into the overall pod, so to speak. Now, once we've developed that incentive fund, right, we actually need a way to distribute it. And again, this was done in a kind of many-to-many model historically when we had many different contracting entities. Now, as a single contracting entity, we can do this in one way that is cohesive, right? So we delegate the credentialing process, and so we own that. We can bring the doctors on board. We align it with contracting, so we can really set terms that are going to allow us to be successful. We use analytics to be able to identify where the opportunities are. We perform against one single clinical program, so we can really focus and perform that way. And then when we drive the performance and drive incentives in, we have a model that is approved by the governance, which includes obviously the board of managers, for how we distribute those dollars. Now, these distributions happen at the tax ID level. That's really important to understand. So for a small practice with one or two physicians, right, that distribution is happening in a way that's very direct. And then for a large group, like the Henford Medical Group, the distribution happens at the TIN level. And then it's incumbent upon the medical group to actually determine what is a way that incentivizes the kind of behaviors we need to be successful in the contracts. And so that's really the case for any tax ID. We want to make sure that we're getting the dollars to that level, and then there's autonomy there to determine what needs to happen. But it's one model for how the dollars go to that level that's approved by the governance of the CIN. I think this concept of the network models as an enterprise is actually really important to make sure that people understand. And there's actually 3 contracting channels, actually literally 3 networks that are affiliated with the Henry Ford system. So the Mosaic Clinically Integrated Network is the coming together of really four kind of entities. So one is the Jackson Health Network. The second is the medical group. The third is Michigan State in the employed providers at MSU. And then the fourth is Henry Ford Physician Partners, which is a type of independent arrangement that we have with physicians who are wanting to participate with us in contracts, but not be fully employed. So it's a very pluralistic design, right? People are coming that are fully independent or might be in PSA relationships, all the way through medical group membership, and that's what comprises the Mosaic CIN, and that's kind of the main vehicle for driving value-based contracting, really all contracting for the provider enterprise. And right now, that's where it's the 600,000 lives and 4,500 providers. And there's a combination of 20 plus payer products. I can also just add here a vehicle that looks like this with over a combination 20 products, nationally speaking, at this scale is very unique. This is one of the largest and most advanced clinically integrated networks in the country in year one. So it's a very sophisticated model, and it's one that others will look to as we continue to evolve this going forward. The second organization to call out is the Henry Ford Physician Network, which is more of a classic kind of physician organization, but it's really kind of an umbrella physician organization. And that PO is really set up to do our direct to employer contracts. The ones that are most notable is General Motors and then our own employee plan. And so what this allows us to do is partner with other physician organizations that may want to participate in certain contracts with us. So the CIN is really single signature. So if you're in everything. It's a very close, tightly aligned, highly integrated model. The physician network is more of an umbrella that's much looser alignment. It's not designed to meet standards of clinical integration. And so it's a different type of contracting model, which is called messenger model. And it allows us to participate with other physician organizations and after we come together in specifically these direct to employer arrangements. And then the third contracting entity is the Mosaic Accountable Care Organization. And the ACO is inclusive of really most of who participates in the HFPN, as well as Covenant. So that's what CHP stands for, is Covenant Health Partners. And what underpins all of this is in a shared administrative structure or shared administrative platform. So whether it's the Mosaic CIN, the Mosaic ACO, or the HFPN, it's the same team, right? The same team that has expertise in credentialing, contracting, practice transformation, elements of quality, community health, and SDOH, right? This is the team that's driving performance regardless of the entity And when I say entity, I'm literally talking about LLCs. So these are 3 different LLCs that are able to enter in contracting relationships with different payers on behalf of the physicians that are included in those networks. And so everybody who's in the Mosaic CIN is part of the HFPN, and the majority then of HFPN is part of the Mosaic ACO, and the ACO is just for that Medicare cohort of patients. So it's actually important to recognize that even though we have different things that are called Mosaic and different contracting vehicles, those are 3 strategically different and distinct, all supported by the same team of folks that are the dedicated, really network support team for Henry Ford. So that team then provides certain services across the various networks, and it's worth calling a few of those out. So really one is about access to payer contracts and value-based incentives. And so the administrative team really supports driving the opportunity to perform in those contracts. Contracts may have some terms that we've tried to really align, but really performing against those aligned terms takes support. So we actually have a team that rounds with the practices and helps individual practices and providers understand where their opportunities are and what they need to do to be successful. That is really what that personalized care looks like. We have dedicated liaisons that provide that tailored support and then actionable insights to optimize their success. The payer enrollment we've talked about to a degree, that's really the credentialing function. And so we're able to take the time for credentialing down by 2 or 3x, and which is important for rev cycle, but also for access for our patients. Compass is a homegrown software tool that essentially sits on top of Epic and does really 2 main functions. One is it helps identify clinical activity. So if it helps reconcile lives that belong to us. And so it's our kind of life management tool. It's also the point of care gap closure tool. So it helps us with identifying where there are gaps in care for patients that are in front of us and close those gaps in real time. Various other technologies that we implement. The EMR is kind of the foundation. We're an Epic shop, and so there's a lot of tools that kind of sit on top of Epic that help us stratify patients and then look for opportunities to then benchmark and drive performance based on the different analysis. And then there's a whole kind of suite of resources and expertise that we provide related to coordination of care, and then also community health and understanding that SDOH or social drivers of health are major kind of drivers, major influencers of health outcomes. And as a clinically integrated network in contracts where we have accountability, we have to drive performance across those contracts, kind of regardless of what is driving the health outcome. So very important to have a robust community health and social driver strategy to support the needs of the folks in the population that we take care of. So to kind of put a summary on this, the clinically integrated network was about coming together and recognizing that we were better together. And I've talked about contracting, credentialing, analytics, a unified clinical integration or pay for performance program, as well as aligned incentive distribution and a team-based approach from an administrative perspective. So those are all ways that we really haven't ever before been together and come together. And so I'll leave you with this Henry Ford quote, which this sport, this value-based care is really a team-based sport. And we will be more successful going after those quintuple aim objectives, performing in our value-based contracts as we do that together. And so the better we're able to come together, stay together, and work together, the more successful that we will be. Thank you for attending this education session. I hope it was helpful, and look forward to and appreciate your performance as part of the clinically integrated network, the Mosaic Clinically Integrated Network. Thank you very much.